Professor Wasim, please.
Thank you very much, Umar, for your kind introductions and good evening and assalamu alaikum to all of you, and thank you very much for your kind invite for me to come and speak at the PS. Let me try and share my screen. Hoping you can see my slides. So I'm hoping you can hear and see me. So thank you very much for your invite today. So the topic I'm going to be covering today is around non-alcoholic fatty liver disease, the view from an endocrinologist. Now, before actually I start my talk, let me try and give you a prelude to the talk today. So we were probably one of the first units in the UK and very few units globally that about a decade ago, we started a joint metabolic liver clinic to start looking at patients for managing non-alcoholic fatty liver disease. So this was done at the Queen Elizabeth Hospital, Birmingham site of the University Hospital, Birmingham, which is one of the largest solid organ transplant units in Europe. The reason we started this clinic was principally for that we had more and more patients with non-alcoholic fatty livers that were being diagnosed or were having the liver transplant. And pre-pandemic, for the first time, we did more liver transplant for patients with non-alcoholic fatty liver disease than those with alcoholic liver disease. And this is just to show the scale of the problem. So today, what I'm going to be talking about is to look at the burden of NASH and advanced fibrosis in patients with and without type 2 diabetes, look at new methods to identify patients with advanced fibrosis, and look at some of the new treatments that are being developed, and overall give you an overview of non-alcoholic fatty liver disease. So non-alcoholic fatty liver disease, as it's called now, although there have been other terms being started to use, we tend to use more like NAFLD in the UK, is that it is an entire spectrum. So it starts with a normal liver, and as we know that in people with diabetes, with the visceral obesity, the fat starts getting stored in the wrong places, and one of the worst places to store the fat is the liver. So initially you get non-alcoholic fatty liver, which is just a steatosis with ballooning of the hepatic cells as seen in the histology in the slide, and this forms the spectrum of the NAFLD, and then it progresses to NASH, where along with inflammation you start getting fibrosis. This is still a reversible stage, and then you get cirrhotic NASH, and the cirrhosis can progress to causing decompensation or even hepatocellular carcinoma. So when we talk about advanced fibrosis, we are talking about fibrosis beyond what is called as the F3 bridging fibrosis, along with F4, which is compensated cirrhosis, and F4 along with decompensated cirrhosis. So it is the entire spectrum. So one of the questions that is frequently asked by a lot of people, that how these patients present first, how they are diagnosed with NAFLD. And this is specifically an issue for a number of emerging economies when NAFLD is being looked into, being diagnosed by various specialists in various settings. So how are they usually found? Is it unexplained ALT or GGT elevations? Or is it that ultrasound which they have got for whatever reason, which shows fatty liver? And this publication from our group by Matt Armstrong actually shows, if you look at the documented reasons for presentations of NAFLD, in 18% of the patients, it is at the time of the diabetes review, where they're diagnosed as having NAFLD. Non-specific routine blood tests, which are done for whatever reasons, account for nearly 15%. At the time of hypertensive disease, review for about 11%. GI symptoms, about 10% of the patients present with GI symptoms, and these include excluding liver-specific symptoms. About 6% present with generalized fatigue or tiredness, and this is again something that is seen. And then you have got other less common presentations. There are very few centers globally which do routine screening or case finding for patients with NAFLD. Now, the overall prevalence and burden of NAFLD, and this is, I'm talking about the whole spectrum from non-alcoholic fatty liver to cirrhosis, varies across the globe, and in the various studies, it's been shown to be affecting nearly a quarter of the population, which is quite huge. About 31% in the Middle East, perhaps slightly less in Africa, but it is something that's affecting a quarter of the global population. Now, what is very interesting, and this is a study that looked at the progression or the annual predicted prevalent cases of NAFLD. So if you look at the NAFLD in the UK, you have got about 14 million cases. If you look at non-alcoholic fatty liver, you've got 13 million cases. NASH with no fibrosis, you've got about 1 million. And NASH with advanced fibrosis is about 350,000. And cirrhosis still about 128,000, with decompensated is about 22,000. About 1,600 of them actually develop hepatocellular carcinoma. And currently we're doing around 232 liver transplants in the UK. So this just shows you the whole spectrum from non-alcoholic fatty liver disease to liver transplant. And it shows that the progression is not seen in all patients, but it's the tiny minority of the patients that progress to decompensated cirrhosis. Therefore, it's very important to identify these group of patients that is going to progress to compensated or decompensated cirrhosis, and to have adequate management strategies to stop that. Now, to really understand the scale of the problem, this is a very interesting study that was published from the United States. And this is a study that looks at the prevalence of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis among a largely middle-aged population, utilizing both ultrasound and liver biopsy. And there are very few studies that have really done that. So this study was done in nearly 2,000 individuals aged between 18 to 70 at Brooke Army Center on active duty personnel and their dependents and military retirees. The exclusion criteria were chronic liver disease, HIV, and alcohol consumption. The average BMI was about 30. About 16% of them had diabetes. 400 were enrolled. And after ultrasound, nearly 156 patients had positive ultrasound. Few of them refused biopsy, so 134 had biopsy. And out of those 134 biopsy, about 40 of them had NASH, and 9 of them have got advanced fibrosis. So this just helps you to understand the extent of the problem and the patients where things need to be focused. And if we break it down by ethnicity, NAFLD and NASH is more common in Hispanics, slightly less common in African Americans. There is very little data in this study from a South Asian population. And in people who had type 2 diabetes, 72.4% had NAFLD and 22% had NASH. So again, it's a slightly skewed study, but it just showing the extent of the extent of the problem. Now, one of the things about fibrosis is that it not only gives an indication of for the progression of the liver disease, but it also has an effect on the all-cause mortality. So if we look into this study, looking at two factors, one is all-cause mortality and the other is the liver-related mortality. And as the fibrosis increases from F1 to F4, there is a steep increase in all-cause mortality. But when it comes to liver mortality, that rise is only seen at between F3 and F4, showing that the all-cause mortality, which is mainly cardiovascular, tends to rise much earlier than the liver-related mortality. So what this slide actually tells us that although it is important in terms of management of liver-related disease, it is equally important to look at the cardiovascular management of these patients, both in terms of the statin use and reduction of cardiovascular risk factors and better management of diabetes. Now, there are a number of non-invasive ways that one can do an assessment for fibrosis. This can be either done through an AST-LT ratio or BARD or FIP score, and through the ELF scores that gives an indication of the severity of liver fibrosis. Less than 7.7 is none to mild, 7.7 to 9.8 is moderate, and greater than 9.8 is severe. We tend to use a T fibroscan, which all patients that come to our clinic tend to have the scan done. And this not only gives us a prognosticate marker, but it also helps us to follow up our patients to see whether the fibrosis is getting worse. We have now also started using MREs in some of our patients. Some of this has been done in the clinical trials. And as you could see, the changes in terms of the kilopascals you start seeing in stage 2 or stage 3 and stage 4, that gives a fairly good idea about the progression of NAFLD. Now, one of the scores that has been developed in the UK and is used widely is called the Camden Pathway. The Camden Pathway looks at patients who have got raised ALT with no excess ethanol consumption, negative chronic liver disease screen, plus a fatty liver on ultrasound. And then you do a FIP score. Now this is available on various webs. And you basically get, if it's less than 1.3, there's a low risk of fibrosis or greater than F3. And mainly it is to manage fatty liver in a primary care setting, and this including treating for metabolic syndromes, weight loss, annual LFTs, and reassessing fibrosis in 3 to 5 years using the pathway. In patients with a FIB-4 score of between 1.3 to 3.25, they have got elastographic measurements done, and if that's greater than 9.5, or if the FIB score is greater than 3.25, then there is a high risk of F3 greater fibrosis, and these patients are generally referred to our clinic or to a hepatologist for assessment of CLD, consideration for clinical trials, and we'll come to that later on in the talk, and considerations for hepatocellular carcinoma and varicose surveillance. And this is what the Camden Pathway. This is the study that actually showed that it is reasonably accurate in terms of diagnosis of advanced fibrosis and cirrhosis, and it avoids unnecessary referrals. Now, when it comes to definition of at-risk NASH patients, what we are really looking at is the current NASH drug development focuses on patients with NASH at risk of progression to cirrhosis. So we're not looking at the patients with early ballooning or inflammation. We are looking at the patients with significant fibrosis or cirrhosis. So this is a NASH score of greater than 4. And the current treatment is looking at both steatosis, inflammation. So with steatosis, it's usually diagnosed by controlled attenuated parameters. Inflammation is the sign of AST, and fibrosis can be measured by liver stiffness measurements. So this is to do with the diagnosis and the prevalence. So what we can do in terms of the management, and this is where the role of the endocrinologist or the metabolic physician becomes extremely important, especially in the current state of drug development and availability. So the main important treatments are the three important wheels in terms of treatment of NAFLD. One is around controlling obesity. So this is either through lifestyle or diet, mostly through hypocaloric diet, although you've got to be careful. Once the patient develops cirrhosis, making them lose weight is not a good idea, especially if they're being considered for liver transplant, because once your liver packs up and you start losing weight, you can become sarcopenic, and that has quite a kind of a mortality risk attached to it. Weight loss medication is being considered more and more, be it GLP-1 agonist, high dose of liraglutide like Saxenda, or other agents like Semiglotide. And then there is always bariatric surgery to achieve huge weight loss. Now, in terms of reducing cardiovascular risk, because again, this is something that's going to kill more of our patients than progression to liver cirrhosis, there is the element of treating type 2 diabetes along with cardiovascular risk factors, looking at hypoglycemia and agents, perhaps that can reduce your cardiovascular outcomes like GLP-1 receptor agonists or SGLT2 inhibitors, management of hypertension and dyslipidemia. When it comes to the NASH or directly targeted treatment, currently the evidence is less, and we will explore this further. There is some evidence with vitamin D, but not in people with diabetes, and there is some evidence with pioglitazone. Now, this is a very interesting study, basically looking at liver insulin sensitivity and liver fat. Similar results we've seen in the direct study, which actually shows that as the liver fat decreases, the insulin sensitivity increases, which clearly means that if the fat deposition in the liver is responsible for insulin resistance, and weight loss by whatever means is able to achieve that, makes the patients more insulin sensitive. So if you look at the effect of weight loss on NASH fibrosis, so this is a prospective study with biopsy proven NASH, in which a lifestyle change was done over a period of 52 weeks. This was a hypocaloric diet of 750 kilocalorie less, walking about 200 minutes per week, along with behavioral sessions every 8 weeks. And what it showed was that in the overall group of patients, there was a 25% of the patients, there was a resolution of steatohepatitis, and this was this really depended upon the stage of liver fibrosis, again showing very good results even in the patients with high score, suggesting that weight loss by dietary intervention does improve NASH fibrosis. We are getting more and more data from the bariatric surgery, and this study actually shows that you could achieve significant weight loss by bariatric surgery, mostly through vertical sleeve gastrectomy or Roux wide bypass, but do we expect similar results in NAFLD? And if you look at the prospective study in morbidly obese patients with biopsy validated NASH, with greater than one comorbidity factors for greater than 5 years, and a meta-analysis of 32 cohort studies, it does show resolution of steatosis in nearly 66%, inflammation in 50%, ballooning in 76%, and fibrosis in 40%. So again, suggesting that bariatric surgery is a treatment option and it will work. But one of the things which is very important and what we do at our center is try and get our patients to bariatric surgery at the F3 level. Once they develop cirrhosis or both compensated or decompensated, and especially decompensated cirrhosis, we tend to avoid bariatric surgery because weight loss at that stage may be harmful. We only consider bariatric surgery after the patients have had a liver transplant, and this or 6 months post-transplant, as this helps in weight loss and at the same time helps in the survival of the graft. So again, this is another study basically showing the percentage of weight loss that is really required in terms of lifestyle modifications to improve liver fibrosis. And generally, if you are able to achieve 10% weight loss, in 80% of the patients, fibrosis is regressed, and in 19% patients stabilize. With less, even with less than 5% weight loss, some benefit is seen. Now, when it comes to treatments of NAFLD and NASH, so this is one of the fascinating and developmental fields in terms of metabolic and obesity and type 2 diabetes and liver research. So currently a number of agents that are being tried. Now, interestingly, these agents could be looked or be classified into two types. So one are these group of agents that are specifically targeting the liver in terms of fibrosis. So this usually falls under the remit of the hepatologist. But a number of other drugs which are looking at metabolic targets are something that is more under the remit of the endocrinologist, and therefore this close working is important. So currently there are greater than 20 preclinical programs globally. 29 compounds are in phase 1 study, 45 in phase 2 studies, and 4 in phase 3 trials. But unfortunately, still, there are no treatments currently licensed in the UK for the treatment of NASH. So if you look at the type 2 diabetes pioglitazone in NASH in patients with pre-diabetes or type 2 diabetes, this was a randomized placebo-controlled trial in the phase 4 study. The number of patients was small and did show regression, greater than 2-point reduction in NAS in 58% of the patients compared to 17 in the placebo group. Resolution of NASH was seen in 51 compared to 19, and greater than 1-point fibrosis improvement in 39 compared to 25, suggesting pioglitazone might work. But one of the issues with pioglitazone now is weight gain, and we have been using it less and less in patients with NASH, both with diabetes and pre-diabetes. Lean study, this was something that was again done at a center that specifically looked at liraglutide, again a very small trial, but what it actually looked at was a liver proven biopsy. So it was a proportion with significant improvement in liver histology. So all patients had liver biopsy. So this was quite a good study in terms of the endpoint, and it did show either resolution or non-progression of fibrosis in 39% compared to 9%. And there was also a weight reduction of about 5% of the weight loss, and the ALTs were down by a quarter. SEMA-NASH was a study that was published, that was presented at the ADA last year. Now, this is a study with semaglutide, and we were one of the centers. in which once daily semaglutide was used, 0.4 milligrams. It had 3 arms. In this, the other arm, 0.2 milligrams was used, and the third arm, 0.1 milligrams was used on a daily basis. And the eligible patients would have had biopsy confirmed NASH. So these were advanced patients. NAS score was greater than 4, fibrosis stages 1 or 2. BMI was greater than 25, and HbA1c less than 10%. Patients had biopsy at the start of the clinical trial. There was a 72 weeks of treatment on top of nutritional and physical activity counseling, and the liver biopsy was done. The trial objective was to compare the effect of 3 different doses of semaglutide subcutaneous once daily versus placebo in histological resolution of NASH. The primary endpoint was resolution of steatohepatitis and no worsening in liver fibrosis in patients with baseline fibrosis stage 2 or 3. And confirmatory or exploratory secondary endpoint was improvement in liver fibrosis and no worsening in steatohepatitis with baseline fibrosis. And these were the results. So in subjects with fibrosis stage 2 or 3 at baseline, there was no worsening liver fibrosis, nearly 58% of the patients, compared to 17 in placebo, and this was statistically significant, suggesting a kind of a diabetes agent, you may call it a GLP-1 analog, actually works in patients with NASH. We also know, in terms of the cardiovascular benefit of GLP-1 analogs in patients with type 2 diabetes, and this is perhaps one of the reasons that we have started using more and more GLP-1 analogs in our patients, especially those with diabetes, with NAFLD. And the main reason is to decrease the cardiovascular mortality and expect some kind of a benefit in terms of their liver. Now, in terms of specific agents which are targeting fibrosis, there have been a lot of agents that have been looked into, which are phase 3 trials. Obitolic acid is an FXR agonist, and it's been shown to be effective in multiple animal models. We have trials with obitolic acid. So this is the Regenerate trial. And this is basically looking at fibrosis improvements by greater than 1 stage and NASH resolution, again showing some initial promising results. And these are some of the other agents, and these are the slides taken passed to me by my liver colleagues who are very optimistic of some of these agents in phase 2 developments that are specifically looking at reducing fibrosis and inflammation in patients. And just to give you an overview of the current trials in development, and these are all kinds of agents that are being looked into. Most of them targeting liver and liver fibrosis, and with reasonable amount of patients, and all of them have got histological endpoints and clinical endpoints for full approval. So when it comes to the current treatment paradigm, so we have got NASH stages F0 to F2. But most of this management is basically metabolic or endocrinological, and this looks at improving lifestyle, making patients lose weight, reducing the cardiovascular risk. Once the patient gets advanced fibrosis, in terms of long-term therapy, we have got some evidence with drugs like pioglitazones and GLP-1s. Very little evidence currently with liver-specific agents, but a lot of work is going on in terms of trying to find the right treatment. So, as I said, initially it's behavioral changes, and then it's weight loss and insulin sensitizers currently, and discrete pathways and combinations to try and improve the outcomes till we get better licensed treatment. So the take-home message is the burden of the disease, nearly 1 to 1.5% of NASH is there. But if you look at the NASH where we need to be concerned about, it's about 0.5%. Still, it is quite a big problem, and it is going to get worse as the obesity rates rise globally. We need to identify at-risk patients with fibrosis strategies and monitoring progression in response to treatments with better monitoring and non-invasive methods. And in terms of treatment, the regulatory alignment offers us very little choice. It's mainly around weight loss and pulsed antifibrotics. So that's the end. So thank you very much. Hello, can you hear me?
I can.
Oh, sorry. Let's stop my video. Can you just restart it if you don't mind?
So thank you so much. We have a question here for you.
Hello. Can I hear you?
So the question is, what is the impact of low dose vitamin E in NAFLD patients with diabetes?
I think there was some concern around again, very theoretical, about increased risk of hepatocellular carcinoma. So that was the kind of very small risk, and that's the reason why it's not really recommended in that group of patients.
Thank you. We have another question.
Sorry, I'm not able to hear you clearly.
So we have another question, that why was semaglutide used in very low dose of 0.1, 0.2, and 0.3?
Yeah, this was a daily dose, not a weekly dose. So I think the reason for using it as a daily dose rather than a weekly dose was for better pharmacokinetics and better effect of the liver. So it was not used on a weekly dose, which is 0.5 milligrams. So if you could see, the dose that was used, 0.1 milligrams every day, is nearly equivalent to 0.7 milligrams. So a higher dose of semaglutide was used on a weekly basis. So this was a daily dose, not weekly.
Thank you, sir. Do we have any other question, please? So we have another question, that
Yes,
what
please.
would you recommend for lean patient with NAFLD, especially regarding the dose of pioglitazone, whether 30 or 45, or is there any other option that you would like to mention, please?
Yeah, I think the difficult one is what is exactly defined as a lean patient, especially if you're looking into a kind of a South Asian context, because in terms of the new definition of South Asians and obesity, it's up to a BMI of 23. That is classified as overweight, and above 25 is obese, which means that in a number of these patients, GLP-1s can be used at a much lower BMI. In terms of the dose of pioglitazone, generally the dose we have been using is around 15 milligrams rather than 30 or 45. And this is mainly to stop the weight gain, because there is no added benefit of using either 30 or 45. So we generally tend to use a dose of 15 milligrams, which improves insulin sensitivity, has an effect on the hepatocyte fat cells and fat transfer into subcutaneous tissue without causing much weight gain or fluid retention.
Thank you, sir. Thank you, sir. Anyone else, please?
In the normal weight patients, would it add anything?
So there's a question that would metformin do anything for the patients who are of normal weight?
In terms of NASH, I think currently there is very little evidence. There was some sessions in some studies were shown that metformin might be helpful, but these are very small studies with large confidence intervals. So I wouldn't read much about it. Currently, there is very little evidence to support it. It might be used for diabetes, and we all use it, but very little evidence in terms of NAFLD or NASH.
Parts of the world, since we are considered as metabolically obese population, what to do once we find a patient having fatty liver on ultrasound, yet the inflammatory markers are normal. So, yet the inflammatory markers are normal. How to proceed with that very scenario?
Okay, so in this group of patients, I think, you know, if you don't have most of these patients who just have fatty liver, they will fall into the category of what we call non-alcoholic fatty liver rather than NASH. If you have got access to fibroscans, you can do that to know the fibrosis score. Now, the Camden Pathway and the FIB-4 score, which I've mentioned, which are now available on the web, that gives you a fairly good assessment to prognosticate these patients. So if the FIB-4 scores are less, which will be if the liver enzymes and the blood values are normal, in these group of patients, the most of the management is around the behavioral side of things. So even if their weight is normal, trying to reduce their cardiovascular risk, and even in those group of patients, healthy lifestyle, because they will have an element of visceral obesity and liver fat. So even if they would be what are classified as metabolically fat, even a small amount of weight loss, about a couple of kilograms, would be helpful. So healthy lifestyle, trying to reduce their calories, improving their physical activities, starting them on a statin in terms of the cardiovascular risk is something that you would want to do.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you, sir. Please pass the mic.
I have got two questions. One is that why SGLT2 inhibitors have not yet been tried in NAFLD or NASH. And second question is which type of bariatric surgery, whether it is the ONY or it's a sleep surgery, which is better as far as the control of NAFLD is concerned.
Thank you very much. I think that's a very good question. So when it comes to SGLT2 inhibitors, I did not show you, but there have been some small trials that have been done with both with empagliflozin and dapagliflozin. The reason, and these have shown improvements. Now, one of the challenges we have got with any trials with NAFLD or NASH is what is the clinical endpoint. So if you're looking at surrogate markers, be it in terms of liver enzymes or scans, they will give you some idea of improvement. And again, there is a lot of noise in the clinical trials, some clinical trials showing benefit, others not. But if you look at biopsy proven clinical trials, which again, quite difficult to do. So with the SGLT2, they are small trials with dapagliflozin and empagliflozin showing some benefit, but we don't know whether this benefit comes from just from weight loss or specifically from the use of drugs. So they are trials that are happening, but these are small. When it comes to weight loss surgery or bariatric surgery in NAFLD, I think the choice of surgery depends really on the baseline weight. So gastric bypass, generally in the UK, we tend to offer it to patients with a BMI of greater than 45 or 50, mainly because this is quite an extensive surgery. It does produce a huge amount of weight loss in patients, but can also cause issues, be it with anemia or micronutrient deficiencies. So if a patient is super obese, then you may consider gastric bypass with all its attendant issues and side effects, and that does have a good effect on NAFLD. But if the patient has got a BMI of about 35, then gastric sleeve is a perfectly reasonable surgery to do because it's much easier to do. It's got much less in terms of side effects. And what you're really looking at is percentage weight loss from baseline. So if you're able to achieve greater than 10% of the weight loss, and from the trials I've shown you, you can actually get a resolution in about 60% of the patients in terms of F3 and F4.